I am so grateful for doctors' data to allow this conversation. I have a fire in my belly to vindicate estrogen. There is so much confusion and so much misinformation. Elbow away the scandemic. Let's really focus on what's going on with estrogen. So I'm going to run through some of the slides. We certainly could have a 3-day seminar on this, but I want you to take home that there is so much data that estrogen has been misunderstood consistently, and it is misinterpreted, and your patients and probably yourself are missing out. So also, because of this issue, Dr. Brownstein, who's like a brother to me, I said to him, you're 61, I'm 75. We don't know how much longer we're going to be here. We really should put together a seminar, make it online so it's evergreen, so practitioners can really understand the science. So the last weekend, Friday and Saturday of April, we're putting on Everything Hormones. It's 16 hours of CMEs for most health professionals. And besides this, we will also have a month later an hour Q&A, and we'll also have 2 free included 15-minute Q&A with myself and Dr. Brownstein personally to find out what you're having trouble with when you try to actually use this information or some case report issues. We really want to pass this information forward. It's kind of like our swan song. So just know about this, and doctor's data said you could have the slide before you start everything. So because estrogen is so misunderstood, the mantra is estrogen drives cancer. And that is how most people look at that today, and that's equivalent to the world is flat. In fact, study and articles just came out from the Mayo Clinic Women's Health Center in Medical News several days ago, and they said, let's face it, 3/4 of women over 60 are overweight, and that makes them much more at risk of what? Inflammation, heart disease, diabetes, cancer, etc. And they said, we have a shortage of obesity and menopause doctors. Why do we have a shortage of menopause doctors? Ever since the misinterpretation, wrong interpretation of the first Women's Health Initiative in July 2002, everybody's gotten the wrong memo, and they've really stopped teaching how to use hormones and address menopause and andropause in practice. That's why we have a shortage. So they said, we know that all of the issues are because there's a deficiency of estrogen. When you don't have enough estrogen, you start putting more weight on your torso. When you don't have enough estrogen, you can't think as well. When you don't have enough estrogen, you don't build muscle because testosterone doesn't work as well to avoid sarcopenia. When you don't have enough estrogen, you get fatigue because estrogen oversees your mitochondria. When you don't have enough estrogen, your memory starts to falter, your motivation, because your hippocampus starts to shrink. And hippocampal volume is the most important anti-aging endpoint that you can focus on. So this article said, let's face it, it's all due to estrogen insufficiency. That being said, since nobody wants to write a script for estrogen, what options do we now have for women? The options, they say the Mayo Clinic and the medical journal that's publishing this article. Well, we have medicines like semaglutides. The American Heart Association last week just okayed semaglutides for the prevention of heart disease along with statins. And we have surgical interventions like bariatric surgery. No mention of really using estrogen replacement. This is the isness, the estrogen isness of menopausal world is flat. So the mantra is hormones drive cancer. You should avoid estrogen. If you replace it, this is the mantra, should be for the lowest amount for the shortest period of time, which is not really what, if you dive into the replicated science, what the science says. In fact, what I've done for Everything Estrogen is go through every single article and study on estrogen and reanalysis of the estrogen-only arm since it first was initiated, all the way through from 1998 when the Women's Health Initiative started, all the way through to the present. There isn't one article on looking at estrogen and the role of cancers that doesn't say that it protects against cancer. What it basically does when it's mixed with synthetic progestins, then there are the issues. So you now see in journals, hormone replacement therapy causes dementia. hormone replacement therapy causes cancer. But if you dive into the bowels, often it's not mentioned in the abstract. And you also have to look at the forest plots and the statistics. If you dive into the bowels of the studies, almost all the time, it's looking at the combo of progestins, synthetic progestins, not natural progesterone, and also an altered estrogen, whether it's ethinyl estradiol, the estrogen and birth control pill, which we used at Tulane as a control for testing whether compounds were endocrine disruptors, or whether it was looking at estrogens when they're synthetic or oral. Oral estrogen is also breast protective, but yet oral estrogen does go through the digestive tract and then the liver, called the first hepatic pass. And when oral estrogen, and in fact, when oral testosterone go through the liver, they make metabolites that are procoagulatory and pro-inflammatory. They make clumpy, bumpy, inflammatory stuff. So those always have a slight increased risk of ischemic stroke or adverse cardiovascular events. But topical estrogen, vaginal estrogen never has those adverse events. We hear that hormones drive, my earplugs got caught in my bracelet. That's kind of funny. We hear that estrogen drives dementia. In fact, I was just speaking at A4M at their longevity conference in December in Vegas. There were 5,500 newbie doctors there. Sea of people, 150 speakers, 30 of us speakers got to be in the main room. I was fortunate enough to be one of those speakers. Half the speakers said, estrogen is fabulous. You can even use it after a stroke. You can use it after the placement of stent. If you've got congestive heart failure, definitely use it. The other half of the speakers said, it drives aging, it accelerates it, and it also drives cancer. I could see everybody just cloud up with confusion, and thus we're having this conversation. Now, I ask you, and when I had Abraham Morgentaler, we lectured together in Miami about 2 years ago. He's the male version of me, so to speak. He's the gentleman that's trying to put testosterone on the map and vindicate it. I'm trying to put estrogen on the map and vindicate it. He started the Boston Men's Clinic. He's an associate professor of urology at Harvard. He said at his lecture this very same sentence that I've been saying. So I cajoled him to be on my podcast, and together we said this statement. So think of Abraham Morgentaler and me saying this in sync together, kind of like a hip hop song. Why would nature make the very hormones that drive humanity be pro-carcinogenic? It makes no sense, but that's not a proof of anything. But I'm saying that, but now I'm going to give you some of that proof, because you'll say, well, that's a nice sentence, but I've heard so much and we're scared to death, and we're scared about our licensure. What if we recommend estrogen and the patient suddenly gets breast cancer? Is my license up for vulnerability? So we're going to talk about that. So our learning objectives is to understand what went wrong with the Women's Health Initiative. I got to move my picture a little bit, out of here. And understand the findings of the 19-year reanalysis. So the Women's Health Initiative was published because the FDA said, since hormones are so great, because up until the Women's Health Initiative, for decades, estrogens were used if a woman had a stent, if she had heart disease. They were used for the prevention of heart disease, which the American Heart Association gave its blessing to. So did Europe, so did Britain. It was all over the world. It was global. It was also used if you wanted to treat heart disease. It was certainly used for the treatment of osteoporosis. Our associations gave their blessing onto all of that. So the FDA said, put your money where your mouth is and let's have some randomized trials. And we also knew at the same time that we're an aging nation. It's prophesized by 2030, the majority of Americans are going to be over 65. Women live longer than men, a half to a third of their life in menopause. If they're going to be really ill, are we going to topple Medicare? Thus was birthed the Women's Health Initiative. The Women's Health Initiative was under the auspices of the National Institute of Health, the NIH, and they got together 40 institutions and they looked at women every which way. And they did many studies on bone dynamics, on calcium dynamics, on even sitting. What is sitting? Prolonged sitting, because that's what a lot of Americans do due to our hormones. But their biggest deal and what it's known for is the randomized trials on hormones. And that's what we're going to talk a little bit, because the misunderstanding of that has made us all go south. I want you to understand that estrogen replacement therapy in a healthy woman actually protects against breast cancer. And hopefully by the end of this short little talk, you're going to feel a sense of that, a molecular sense of that, so that you can breathe a little easier and perhaps tomorrow start giving some scripts to some of your patients that you were a little reluctant to before. I want you to understand the growing list of protective actions of estrogen. Like we have estrogen receptors on every immune cell, on Treg cells, on CD4 and CD8 cells. That's why women who are premenopausal or postmenopausal on HRT would get COVID but die less than men who got COVID. So women got COVID more than men, but men died more. And that was what showed us that it was because hormones have a lot to do with immunomodulatory actions. Hormones are immune protective. And that's why as we get older, we're so much more prone to all kinds of illnesses, autoimmune diseases, and especially pneumonias. The lungs are lined with progesterone receptors. So what did Mount Sinai do? They said, wow, let's take some guys that have severe COVID in the ICU and let's give them 100 milligrams BID-IM of progesterone and along with standard care and compare them to patients who only get standard care. And they've published this in peer review. What happened? The men on progesterone had shorter hospital times, less ground glass appearance, less need for antibiotics and complications. Why? Because understanding hormone physiology, wherever there's a receptor, a ligand is searching out and has an action. We've got lots of receptors for progesterone in the lungs. You can then use progesterone therapy in people with chronic or acute, in this case, lung conditions. And also the biggest thing I want you to grasp is the largest study that's ever been run on hormones by our own National Institute of Health and National Library of Medicine. Thank God there is a God that the United States did this study, the largest study ever. And I want to get to this, so I'm going to move on. But HRT is not just about perimenopause, postmenopause, and andropause, and I'm not going to go into this too much, but we now know because of endocrine disruptors, especially in the egg and the sperm and the placenta and mother's milk, so all the pre-gestational periods that really matter about setting up your genome as you become an adult, we now know that we are having all kinds of alterations because we're having blockers of normal hormone action. And this is contributing to the ADHD, to the Asperger's, to the cancer incidence. As of 2016, there is a huge rise in the United States of breast cancer in younger women, which is women under 50 years old. But what's the big deal is that in their 20s and 30s, we have young men and women who have almost no hormone. In young women, we're seeing elevations of follicle stimulating hormone when we shouldn't see it for a few more decades. So just so you, a little teaser, just so you know, hormones are not going to just stay in the peri and postmenopausal domain. They're also going to start moving into all of your patients. So all of your patients should get a hormone test at least once a decade. That's a clinical pearl because we now have a lot of young women who have body dysphoria, anxiety. On functional MRIs, the areas that have to do with higher executive cognition are shrunk a little bit. They've got bone osteopenia. Why? Because they don't have enough estrogen. And Harvard and the neuroendocrine unit of Mass General have been doing randomized controlled trials for a year and a half, giving estrogen replacement and progesterone replacement, just like you would do to 60-year-olds, giving them to 13 to 24-year-olds and tracking the data. And there's now about 30 to 40 studies like this. Yes, this is what's coming down the pike. So I whet your appetite on that. We'll go into that in everything hormone. Well, the Women's Health Initiative is where we all went awry because before the Women's Health Initiative, hormones really started first in ancient China, but let's bring it into contemporary times. It really got its start in the United Kingdom about the 50s, and a lot of it due to Katerina Dalton, who was a physician who came up with the term premenstrual syndrome. And she actually used progesterone anywhere from 300 to 1,000 milligrams to normalize aberrant behavior in the luteal phase. So England was really using a lot of estrogen. The promise at first was if you were on estrogen, that aging was an estrogen deficiency syndrome in women. If you went on estrogen, you could be feminine forever. But then when they started to see its benefits on bone and heart, etc., even hair follicles, right? Women on hormone replacement lose hair less. And that's a devastating thing as women age and they start to lose their hair. So all the way through in England, it was picking up steam as a treatment. and as a prevention. And then the FDA said, cool, we're doing the Women's Health Initiative because we're an aging country. We don't want to topple Medicare. Let's put our money where our mouth is. Let's do randomized trials. So the Women's Health Initiative, and you don't have to read all these details, but 40 institutions, including Harvard, got together, looked basically from 93 to 98 at a large number of women. And there were two groups. One group was on estrogen only, but it was pregnant horse urine estrogen, conjugated equine estrogen. The other group were, and that was a group of women who did not have uteruses, because already they knew in the 70s that when women took estrogen without progesterone, there was an uptick in endometrial cancer. So everybody knew you really should take estrogen with progesterone. But the mantra became, if you don't have a uterus, you don't need any progesterone, because there's such ignorance about receptors for progesterone being all over the body, especially in the brain, especially in myelin sheath, especially in the coronary artery. But the mantra became, if you don't have a uterus, you don't need progesterone. So that was what birthed the estrogen-only arm, women who didn't have uteruses, and they gave them only oral horse estrogen, and the combo arm was oral horse estrogen with medroxyprogesterone acetate, the most commonly used synthetic progestin. And together, that was the number one selling drug. When they came together in a drug, it was called Prempro. And Prempro was like statins are today. It was the drug because everyone thought they could be feminine forever or healthy forever. And as I said, we're an aging nation. And if you look here around 230, 35, the majority of Americans are going to be like me, a little old lady. And so this is just more slides like that. I kind of want to run through this. So women, when the Women's Health Initiative came out, I guess I'm missing, the Women's Health Initiative came out, the combo arm was stopped prematurely. I guess I'm missing a slide here. Sorry about that. I'll put that in when I give this back to the doctor's data lovely colleagues. They said, we're seeing a little bit of an uptick in breast cancer. We're seeing a little uptick in heart disease. So they prematurely stopped the combo arm. They never stopped yet the estrogen-only arm because there was no increased incidence of any issues. And it took a little bit of time for that first hepatic pass issue to show up. And a few years later, there was a small uptick in ischemic stroke. So they stopped the estrogen-only arm, but there was never any increased incidence in breast cancer. In fact, there have now been about 20 reanalyses from 2002. July 9th, 2002 is when the first news came out on media that hormones were bad for you. And it's crazy. If you read editorials in some of the medical journals, they said, where do they even get these statistics? How are they spreading such fear? Because we don't even have all these statistics yet. And fear sells in the United States, and we're a litigious society. And that's created a lot of problems mixing in together with the misinterpretation of the Women's Health Initiative. It's really the terrain that we have here with fear sells media greatly. And we also have a lot of litigious action that goes on in the United States more than any other country. So everyone's afraid of losing their license or being sued by patients. So so everybody stopped using hormones when the first combo arm was stopped, but the estrogen-only arm wasn't stopped. And Leon Spiroff, who you've all read his books, Clinical Gynecologic Endocrinology and Infertility, he was a professor when I was in Oregon. I went to National naturopathic school for a few years, and I went to Western states, and I would go over and hear him talk. And he would say, don't throw the hormone baby out with the bathwater. For decades, we've seen benefits, especially heart benefits, weight benefits, brain benefits, eye benefits. Why do you get macular degeneration and dry eye more when you age? Because you got estrogen receptors all over your eyes. But nobody was listening to him because fear and litigiousness, well, what a recipe that is. It really causes fear. So it was prematurely stopped. And I spent several years writing Safe Hormones, Smart Women, going through every single detail, trying to figure out what was going on. Because I'm a DES daughter, and I'd had breast cancer, as many DES daughters do, but I had so many surgeries and so many issues, and then kidney cancer. So I lost a kidney and an adrenal gland. I was minus so many organic organs that I didn't think I could survive well without being on hormone replacement therapy. So I cared, one, for my patients and two, for myself, to see what is the truth behind this, and can I safely take hormones and not be putting myself in a conundrum or in a huge pickle. So the WHI was stopped prematurely, but not the estrogen-only arm. It went forward, but only for a short period of time, till there was a slight bump in ischemic stroke. But the estrogen-only arm never showed any increased incidence in breast cancer. So mind you, the estrogen-only arm has been reviewed from the Fred Hutchinson Research Center. Fred Naftalin has done extensive research and has come out and published articles saying women are missing out on the benefits of estrogen because the way that the premature Prempro combo arm was stopped made it sound like estrogen was bad when it was the synthetic progestin. Okay, so what happened? So there's all these different reanalyses that aren't making any news media. People are getting really uptight. They're stopping to teach menopausal medicine at Yale and Harvard. And I think a lot of naturopathic colleges weren't teaching hormones anymore. And of course, chiropractic schools aren't doing that, except in New Mexico, where they've got the right to write scripts in New Mexico. So maybe some of the colleges were doing it. But there were many reanalyses from 2002 up to 2019, but none of them made any splash. Come to December 2019. Every year, I'm in Austin, Texas, talking to you from Austin. So down the road, I-35 is another town called San Antonio. Every year in December, San Antonio has a very infamous breast cancer symposium where specialists and scientists from all the best gynecologic and scientific and epidemiologic and endocrinologic and toxicologic parts of universities come together to share their data about how to keep breast cancer patients safe. And at this conference, the same authors of the Women's Health Initiative did a final 19/20-year reanalysis. It's out now almost 20 years, kind of in between 19 and 20 years. And they basically said, and it was presented by this gentleman named Jabowski, who I have a lot of respect for. And it was presented in Medscape Medical Oncology. It was a 19-year reanalysis. And what did they say? They stopped the estrogen-only arm about almost 2 years after the combo arm was stopped, but because of slight adverse heart issues, not breast cancer issues. And they kept having reanalyses, and they kept tracking these women even though the arm was stopped. So at 19-year reanalysis, the original authors took a look at these women who had been on conjugated equine estrogen oral, right? That's Premarin. Oral. That's the very first estrogen that was okayed by the FDA in 1942 was Premarin. So Premarin's been used for a really, really long time, and it's got 50 different horse species estrogens in it. And what we've learned from this reanalysis, because we used to think only bioidentical hormones were great. Now we think any hormone is better than no hormone as long as it's not a progestin. They said, look it. Women who were on estrogen for an average of 5 years had a 23% incidence of getting breast cancer. And if they do get breast cancer, they have a 44% reduction of dying from it. Nothing has ever been so fatality incidence protective as estrogen. That's extraordinary. So that means that if you initiate hormone replacement therapy and you get breast cancer, you're in a better position than if you didn't initiate breast cancer. Instead of suing the provider that you think was the cause of your breast cancer, you should shake their hand. And in any disclaimers that you have in your office, another pearl, you should let people know that this is really the truth of it. If you've been on estrogen for at least 5 years and you go on to get breast cancer, and Leon Spiroff has written about this, they're more differentiated, more slow growing, less life threatening, you do better. Estrogen is protective. It reduces fatality incidence by 44%. So who said this? It's not the same with progestins. With progestins, there was a 45% increased incidence. And what did we just make available OTC a month ago by the FDA? Birth control pills. And what are oral contraceptives? But they're ethinyl estradiol and they're synthetic progestins, the very things that we know are endocrine disruptive and pro-carcinogenic compounds. So it is clear that the risk, both positive and negative, continues beyond using the hormone therapy for at least 10 years. Now they think that if you're on hormones for 5 years, you get the benefit up to almost 19 years, 10 to 19 years. They don't know exactly, but it's long term. So if patients are worried about hormones, it's great to start them in the perimenopause. That's when you get the best results, but it doesn't mean you can't start them in your 80s or 90s. You just don't get as deep a result. But if you initiate hormones in your perimenopausal and early menopausal years, which has been labeled, and I don't like it, the estrogen window, it's been shown that down the road, 20 years later, you have less osteoporosis, better bone integrity, you have less stroke because it protects a part of the brain that is affected for a variety of different kinds of strokes. It's extremely protective and especially against cancer. So the 19-year analysis said that estrogen was very breast friendly. And who said this? Who were these original authors? I'm just going to name a few of them because we've got a lot of ground to cover here. The Los Angeles Biomedical Research Institute, the Fred Hutchinson Cancer Research, Brigham and Women's Hospital, that's Harvard, Stanford Prevention Research. It was the big guys. These are the guys that put their names on stating this, but this did not make any media. I remember giving a talk for PCCA in front of 1,000 pharmacists about a week after this came out at Caesar's Palace in Vegas, and the whole room jumped up and gave a standing ovation. But it certainly hasn't disseminated out into most practitioners, most students of medicine. I'm including naturopaths and patients. We still think estrogen is bad. So scary headlines sell. The standard of care is not reflecting the science at all. Estrogen Matters is a great book that I highly recommend you get. Avram Blooming, who I interviewed for my book, Safe Hormones, Smart Women, although he's not a proponent of bioidentical hormones, he's a proponent of Premarin. He basically, it was the oncologist in Southern California when originally, breast cancer used to be a horrific diagnosis because the surgical interventions removed so much of the torso and women were disfigured, and breast cancer was horrific. People were scared to death to get it because it meant you would almost become a monster. He was able to show that with conservative care, with a lumpectomy and radiation or chemo, you could get the same outcomes, safety outcomes that you could get without these in-depth, severe surgical interventions. So he already was a paradigm shifter on one level. Now he's trying to be a paradigm shifter, like I'm trying to be a paradigm shifter, to let you know that this tool should be in your tool bag. And he has started a 26-year study of giving breast cancer patients who are ER positive estrogen right after their diagnosis. And so the fickle finger of fate, his wife got ER positive breast cancer, and so did his daughter while he's doing this study. And none of the women have had worse outcomes. And in fact, up until the Women's Health Initiative, there were actually 26 studies where they gave women with ER positive breast cancer. One study was done at MD Anderson. One study was done at the University of Wisconsin. One study was done at the University of Georgia. Some of these were heavy hitters. One study went 30 years. One study went 10. Avram Blooming's went 26 years. They gave women who had breast cancer estrogen, and they had matched cohorts who were given either placebo or they were just monitored. It wasn't blinded in all of the studies. And in not one of those 26 studies did any breast cancer patients do worse. In fact, if they had a recurrence, they tended to die less. And that is a theme. If you're on hormone, estrogen, not progestin, especially topical or vaginal, those are the two best delivery modes that the 7 million study will tell us in just a short time, you tend to really fare better. So what about high-risk women? So I was just telling you, here's one of the studies. These are some of the studies that showed this. So I put out a little ebook summarizing all this on my website. I think I sell it for $9 or $12 or something like that. So again, I ask, why would Mother Nature make the hormones that drive humanity be pro-carcinogenic? And you start with your parent hormones, estradiol and estrone, and then you go to the catechol estrogens, and iodine takes the 2 series to the 2-methoxy series. And the 2 series and the 2-methoxy series are our own natural chemotherapeutic protectors. and also our signals that go to estrogen receptor beta. We have natural chemotherapeutic compounds inside our body that are made from estrogen. So because I'm a DES daughter, I had breast cancer, I had kidney cancer, I had multiple other tumors, I had multiple surgeries. Everyone said you got a lemon body and you just got to suck it up and age gracefully. So I dove into the literature to find out the theories about why DES, diethylstilbestrol, caused cancer in so many of the offspring. And I went and spoke with a lot of the researchers, the original DES researchers at Triangle Park. And they said, oh, well, DES tamps down tumor suppressor gene P53, which is our grand-dam tumor suppressor gene. So I sleuthed the literature as to what might upregulate this in me, and lo and behold, it's 2-methoxyestradiol. It reboots tumor suppressor gene P53. So nature has a way, if you can methylate, if you've got B vitamins, which are all cofactors, if you've got vitamin A and iodine and magnesium and B6, if everything is in balance, if things are working right, you make your own cancer protective compounds that are not agonists of estrogen, but they come from estrogen. And this is why estrogen can be breast protective, and not just breast protective, but ovarian protective and uterine protective and prostate protective and brain protective in ways that are extraordinary. Nature has designed for all of this to keep estrogen safe if these right mechanisms are working, which is what a good functional doctor will do. Is the patient methylating? Do you see these in the urine? Does the patient have more of the 2 series than the 4 series, which can cause more DNA addicts and damage DNA? And of course, cancer initiates by damage of DNA. So nature has a full circle where estrogen does have growth signals. Yes, everyone's scared to death of estrogen because it causes growth. Cancer is growth out of control. So people are all crazed. Endometriosis has too much growth. Cancer has too much growth. So estrogens become bad because they think it's driven by estrogen. But within our body, nature has given us lots of ways that we caretake estrogen to keep it safe. Remember Semmelweis, when everybody said he was insane? I think that's what's going on right now with estrogen. This is the 24 follow-up by Dr. Blooming with his ER positive. And why am I giving this talk today? I'm going to really run through this. In the 1970s, I've been in practice 53 years in one way or another. Hard to believe. Oh my God. And Dr. Wright was one of my main mentors, and he's been known as the father of bioidentical hormones. And I happen to write Hormone Deception. The last third of the book shows you how to decrease your exposure in your home, where we get most of our exposure in our food and office and supermarket cart. We've got to learn how to decrease exposure in our patients because we're setting up altered hormone signals pre-genetically. And that's what we need, our green pregnancies, and we need providers to do this. So I was a scholar. William Toscano was one of my mentors, and John McLaughlin. He went on to become the academic dean of the School of Public Health at the University of Minnesota. So he had me do grand rounds there and teach there and use my book in the environmental health science. So here's Elwood Jensen, who discovered the first receptor. Here's Yanaki Gustafsson, who discovered the second receptor. So why would you in practice, if you do decide to give hormones, do Estriol or along with estradiol as biased versus estradiol? So he's the father really of biased, you could say, because estriol basically signals ER beta. And Yanaki said ER beta is our natural chemotherapeutic molecule besides the 2 series and the 2-methoxy series. It's anti-inflammatory and it's a growth controller. And in a local tissue, the balance between ER alpha and ER beta is what oversees tissues. He developed all of this, and Elwood Jensen discovered how hormones work in 1986, and Yanaki discovered ER beta in 1995, and he was wooed at the Karolinska Institute. But now he's in Houston trying to make breast cancer drugs that signal ER beta. Because nature always has a plan for what it does. So if we have growth from estrogen, we also have controlled growth from estrogen. And whatever signals ER beta, he calls this our natural chemotherapeutic compound. He's using agonists that bind ER beta to treat ovarian cancer, glioblastoma, almost an untreatable cancer, multiple cancers. What signals ER beta to keep it? Well, if you're looking at botanicals, it's apigenin, milk thistle, dandelion, some of the broccoli sprout powders and so forth, and also oats and estriol tremendously signals it. 90% of the time, estriol signals ER beta rather than ER alpha, which is a growth promoter. Also, the third metabolite of testosterone. Testosterone goes from testosterone to dihydrotestosterone to its third metabolite, 3-beta-diol. 3-beta-diol looks exactly like soy isoflavones, looks exactly like estriol. 3-beta-diol, that's why Rebecca Glasser has been doing such incredible work treating breast cancer patients, ER positive, right after they're diagnosed with testosterone, because it's signaling this ER beta. So nature already has estrogen worked out to protect us and keep us safe. Why would nature have a hormone and just say it just is a growth promoter and it just is an accelerator? It's not that way. It is part of a functional balance. It's the balance. And that's why when Yanaki first came out with his paper on ER beta, the picture on the cover of it was the Justice Scales of balance. So I've been a breast cancer survivor. I'm 30 years out now. I guess this is an older slide. And I don't know if you know this, that tamoxifen was introduced, I think, in 1974 by Craig Jordan. And up until tamoxifen was introduced, the way that they used to treat metastatic breast cancer was high-dose estradiol. That was the treatment for breast cancer, 6 to 10 milligrams of estradiol. So if estradiol was used effectively to treat metastatic breast cancer, and it was standard of care until tamoxifen was standard of care. If estrogens were carcinogenic, how would this have been? And as women get older, we have less estrogen. So, we should have more cancers when we're younger than when we're older. And when we're pregnant, which is the most hormone exposure we'll ever get in a lifetime, we should have worse outcomes from being pregnant. But after the first year of pregnancy, where there's a slight increased risk of breast cancer, the rest of a woman's life, after giving her body up 9 months to have a baby, nature regifts that woman with protection against breast cancer. In a 1993 editorial in the New England Journal of Medicine, 2 endocrinologists from Harvard stated, on the basis of what we know now, all women should be on hormone replacement therapy. Medicine is trendy. It's like when I was young, you saw Volkswagen bugs, and then you see Priuses. And now you see Teslas. It's all trendy, trendy, trendy. Diseases. Candida Cook told us all about Candida. Everybody had Candida. Now everybody's got mast cell degranulation. Everything goes in cycles and trends. But the problem is that right now we're in a bad trend with estrogen that's not accurate. And we're an aging nation with more older women. And these older women who we should love, they're the women who older lives matter, but nobody's caring about us. We need estrogen to be able to really remember old memories and keep remembering newer ones. Epidemiologic studies do not show estrogen as the culprit. Well-defined epidemiologic studies of estrogen therapy do not suggest an overall increase in the risk of breast cancer. And I'm not going to go through all of this, but in everything estrogen, there's lots and lots of studies. And what's even shocking is BRCA gene studies. So BRCA genes are tumor suppressor genes. And when they're glitchy, women get more cancers. In fact, women who have positive BRCA genetic glitches have an 80% increased risk of not just breast cancer, pancreatic cancer, stomach cancer. You can't do a whole bodyectomy. So this Angelina Jolie has made women much more open to getting double mastectomies, but there's multiple studies that show in presentations where BRCA gene positive women who have been on hormone replacement have less breast cancer than women who are not on hormone replacement. And they're replicated studies on this. And these are just some that you can look at for yourself. Here's another study from that. So women diagnosed with breast cancer while on hormone therapies or while pregnant tend to do better than women who are not on hormone therapies. Pregnancy is the highest time, as I just said, and these are some of the slides. Women who haven't had any children have an increased risk of getting cancer by 30%. That's why MCF7 cells, which they use experimentally in the lab to test ER-positive breast cancer, those are from a nun that got breast cancer, because nuns have the highest incidence of breast cancer of any group of people because they really don't get pregnant. Pregnancy is protective, and it's a it's a storm of hormones. So something's going wrong with our perception of estrogen. And I'm going to look and see where we are with time. So I'm going to just go through this. I'm going to go to the 7 million study. Cache County studies were published a few months after, we're all worried about dementia. The Cache County studies came out in November, and the first fateful Women's Health Initiative was in July 2002 and November of 2002. They looked in Cache County, Utah, and it was a prospective study where they took people that didn't have dementia, followed them into the future, figured out who got dementia and what were the confounding variables. And if women had been on estrogen for 10 years, they had a 50%, depending on the study that was spun off. There were 50 studies spun off from the Cache County study. So different studies had a little bit of different perspectives. But what it is that estrogen can reboot the volume of the hippocampus, which is where your motivation and your memories and your sense of self live. 50% reduction in getting Alzheimer's. If Dr. Oz said, we've got something that's going to reduce your risk of getting dementia by 50%, you'd go to Walmart and all those shelves would be empty like they were during the pandemic. The Arizona Brain Study, they looked at 400,000 women and they looked at their trials, and the women who were on hormones had significantly less neurodegenerative disease, and the ones on natural steroids had much less. I wrote a book on Sexy Brain on how hormones rule the brain, and watch out, we're having gender bending and the environmental threat of castration, which is now showing up coming down the road. This book came out in 2017. But I'm going to go here to because where's my, I guess I don't have my 7 million study. So I'm going to go talk to you for 1 second because I want to take questions. So now I see where I am with my slides. Estrogen is everywhere in the body. It rules immunity. It rules T cells. It rules B cells. Your thymus has receptors for it. As I said earlier, CD4 and CD8 cells are much more functional if estrogen is allowed to signal in the receptors that's also on these cells. It rules Treg cells. Estrogen boosts interleukin-6, our most pro-inflammatory cytokine. A cytokine is a signaling molecule, but the hormones are the most powerful molecules we have because they can talk to genes. And that's where all our archival information is from our lineage. Everything else can talk and have crosstalk, but not to genes. That's why they're the top of the heap. But they're not trained in med schools like they are. They're relegated to gynecology, urology, endocrinology, but you have receptors all through the digestive tract. You've got receptors in your esophagus. You got receptors in your brain. They should be integrated into all genres of medicine, but they're not. So we have cytokines, which can't speak to genes, but they're also signaling molecules. They can't cross that cell membrane and go into the cytoplasm. Your most pro-inflammatory cytokine is interleukin-6. And as we age, we get a lot more interleukin-6, and that puts us at risk of heart disease, obesity, and diabetes. Interleukin-10 is our anti-inflammatory. That's what squelches out inflammatory fires. What upregulates interleukin-10? Estrogen in women and testosterone in men. What upregulates memory? Why can't I speak like this at this age? And not a lot of 75-year-olds can do this data. Is because estrogen promotes memories in women and testosterone promotes memories in men. The big deal, though, to me, where I've really gone clinically dove deep with this, is we all talk about leaky gut. And enterocytes open and close with adhesive proteins between the enterocytes. Well, on those adhesive proteins, you've got receptors for progesterone that has everything to do with upregulating occludens and very 40 different adhesive proteins that help the proper opening and closing of the lining between the outside world and the inside world. Estrogen also has receptor sites on these adhesive proteins. And of course, testosterone helps us make secretory IgA in the gut, which is our gut immune system. And that's why men have one of the reasons why men have a lot less of the 159 known autoimmune diseases, except for the renal one. So looking at the gut, open, close, ER beta is which is estriol, is a main signaler of these adhesive proteins. So people say, why shouldn't I just use estradiol? Well, I say, first of all, estriol, Yanaki says, protects us against cancer, but estriol also makes sure that these open, close, it makes your gut work better and helps you heal leaky gut and make sure that LPS doesn't go into the bloodstream and put the immune system on overdrive. So once you understand the physiology of hormones, you can use them for perimenopause, menopause, andropause, but you can also use them. So I use a lot of hormones in my inflammatory bowel disease young women in their 20s who are facing colectomies, and in less than 6 months, we come back with normal colonoscopies, utilizing many things like low-dose naltrexone and high-dose fish oil and identifying food sensitivities, but I give them estriol. I give them hormones because I know where those hormones signal, and then I can use them. And that's what we're going to go over in everything hormones. But the one thing I'm going to close with is the 7 million study, which is extraordinary. So it's the largest study ever run. We heard about the Million Women study that dissed hormones, but all that was a telephone survey when women were going in and getting mammograms in England and Scotland. It sounded big, but it was not big. The biggest study ever run on hormones was run by our NIH and our National Library of Medicine. It's just not yet out of peer review. They looked at 7 million women that were Medicare. So they have all their records. And they said, how many of these women are on estrogen? 1.5 million women were on estrogen, American women, that they had all the data. So they did a deep dive and they said, what's their incidence of breast cancer? How long have they been on it? How did they take it into the body? What was the dosage? How long did they live? What was the incidence of 5 cancers: breast, ovarian, uterine, colorectal, and lung? They also looked at neurodegenerative disease. 1.5 million women that they had all the data. What did they find? Women on estrogen had statistically less of all 5 cancers. That they only looked at 5 cancers. Statistically less of all 5 cancers. They lived 20% longer. They had less heart disease unless they took oral estrogen, then they had a slight bump. All the literature has a theme in it. It all resonates when you go through if you step back and look at the body of literature over the last few decades, there is a theme. The theme is progestins are not good. Oral isn't ideal, but it's not bad for a short term. But when you take it longer, there's that risk of ischemic stroke. But oral in high doses does cause dementia, especially if it's mixed with progesterone. But transdermal or vaginal delivery never creates problems with dementia, never creates problems with cancer, never creates problems with people who have procoagulative genetic diseases like factor V Leiden. Yes, they can take hormones. They shouldn't be denied, but it just has to be topical or vaginal. In fact, there's numerous studies that show that if you take your hormones vaginally, that got the best endpoints in the 7 million study. That is a huge study. And the message of that study is estrogen helps protect. And the other message that resonates through all the studies that the 7 million studies said that is not standard of care is that older women fared best if they were high-risk cardiac patients like congestive heart failure, high blood pressure. They did better on hormones, lived longer on hormones, had higher quality of life. What else did the Women's Health Initiative studies say? They had a lipid study that was the most incredibly run. They started out with almost 200,000 women and ended up with a few women at 90 years old. And they looked at their LDL, HDL, how long they lived, mobility, and pain. Women who had the highest level of lipids, LDL, wasn't a matter of HDL. High LDL meant that they had a much better opportunity to live with less pain, more ease, more movement, and a better quality of life to 90 years old, which the author said we better reevaluate how we treat older women and their lipid levels. And what was the other big study out of it was osteoarthritis. Joint pain is a big deal. Women's hands and joints, when they start to hurt, it's a nightmare, but we offer them meds. But in the Women's Health Initiative, the women on estrogen had substantially significant decreased incidence of joint pain and increased joint mobility and better life. Through the literature, it's a positive understanding of estrogen, but nobody's talking about it this way. I've had breast cancer. I'm a DES daughter. My life was ruined by hormones and also saved by hormones. I'm here because I don't want my sisters of the heart, who I consider all the women on the planet, to miss out. I've had access to these things against my own. Every year I go back to my breast cancer surgeon because she's got the best palpatory fingers, because I don't want to get a mammogram every year. In England, if you're over 50 and you've had breast cancer and you haven't had a recurrence in 3 years, they let you do it every 3 years instead of here in the States where it's every year. I don't want to get all that ionizing radiation. So I go to her, and she's been aging and aging and aging in front of my eyes. And I've been looking better and better. And she says, because at the women's reanalysis, once we figured out it was breast protective, I went higher and higher with my dosing. And every year she says the very same thing to me. She says, you look better than any other breast cancer patient I have, and you got to get off hormones. And I said to David, we need to do something, because that's what doctors are telling patients, and that's what med schools are telling med students, and scaring the new doctors coming out. So Doctors Data, thank you for this opportunity. And I'd like to take some questions now, because I'm sure there are a lot.